So we bridge the gap between both of these worlds, between the conventional implants and the basal implants with the bypass implant. Okay, why we just ask a question, why not integrate the advantages of the single piece design into the established science of osseointegration? Okay, so bypass system emerges as the world's first commercial single piece osseointegrated tissue level implant system, combining the strengths of both the worlds, combining the strengths of the osseointegration involved with the benefits of the single piece design. Right, we also have a cement retained option as well as screw retained option with this system. So, what is the foundation of the bypass implant system? With the years of research and one piece innovation, we built on the decades of advancement from the osseointegrated root form implant and addressing the limitation of the two piece design, unifying the implant abutment junction into one, redefining the simplicity, strength, and the biological stability of the implant therapy. How did we manage that? We manage that through these three designs. Okay, so in the bypass implant we have three key designs. One is an entirely a smooth surface design, one is entirely a rough surface design, and one is a hybrid design having both apex and the crestal threads at smooth surface, whereas the middle third is the surface treated part.
Excuse me, sir.
Yes sir. So actually
So
I
this
just
is
got a
Dr.
call in
Pritish.
between and I lost the track. Yes sir.
Sir, this is Dr. Pritish from Odisha. Uh,
Okay, Dr. Pratish.
I was listening to one of your old videos yesterday, which was uploaded on one of your old webinars. Okay, um,
Mhm.
uh, in that, sir, that was also beautifully explained. It's a 1.5 hour old video webinar of yours on tornado implants.
Mhm.
So in that you had B and W and BW type of implants.
Exactly. So that was the basis when we developed the system. It was developed by the modification of Tornado itself.
Okay, okay. No, because now you're saying it as bypass implant system. So
So we
I may be a
basically
little.
yes sir. So sir, what basically happened was earlier we were there with the Tornado implant system. Okay, so Tornado was a part of the basal implant system. But when I
Okay,
started Tornado as the other implant indications for delayed loading, and it was highly successful. So that formed the fundamental basis of the bypass system. And then what we did was we separated it from the basal implant. Okay, we
oh,
made it an entire system in itself. So basically,
okay,
what happened is because of our research and development, we came up with the design that was one piece, just like the basal implant, had tissue level abutment. Okay, so can you please mute your mic? A disturbance is coming. Was a tissue level with a tissue level abutment. A smooth transgingival collar was there, engineered for flapless and graftless approach, and immediate or delayed loading was possible. There is no compulsory immediate loading with the system, and this design helps us to eliminate the micro gap problem at the bone level. You got it. Basically what we did was we took a conventional implant, made some changes and made it into a single piece. So the science is the same of the osseointegrating implants. The science is the same. So science is not of the basal implants. The abutment part, the one you see above, let me clear the slide. The one part that you see above the threads, this we derive from the basal. The part below it we derive from conventional. We unified the both. Okay, so that gave us a numerous advantages. So one was the flapless placement was possible, minimizing surgical trauma and preservation of the periosteum. Just wait on a minute.
uh,
And the single drill protocol was still being able to employ. We now
but
call it
sir,
as a neo. Yes, sir.
sorry, sir, sorry for interrupting. But sir,
Yes, sir.
I was just seeing that BBW, those tornado implants were also of the same design. I mean, I agree to the fact that now in bypass you have introduced delayed loading and screw retained processes. I think that is the main difference. because otherwise the
So
implants,
that's
though I have not
that.
physically seen them, though I have not
Okay.
physically seen them or used them, and that was the reason because I came across your that video today. I have logged into this webinar of yours. It was very interesting actually. But
Okay.
even that and this, it looks the same actually. As you
Okay.
just
So sir,
shared your
my tabletop is visible. I'll answer that question. So the key differences that we have
yeah, between
with the
tornado
bypass
and
system,
bypass. Yes, yes.
the bypass and a tornado system. Basically, it's a tornado served as the fundamental basis of the bypass implant. My tabletop is visible to everyone. My tabletop is visible.
No, doc, it is not
Uh,
visible yet.
no, no, no. You are on the
Sir,
screen, sir. Not the.
so
You are on the screen, sir.
can you please pin my tabletop? I think my tabletop spinning was lost.
It is there in the down screens.
I think I have my when I had the call na. जय sir, please मेरे tabletop pin कर देंगे. Just sir, please. So for now, I will just let you know. So the main difference is with the tornado implant, the tornado system. It was a part of the basal system, right? So in basal there is not any kind of anti-rotational groove present. So if you do a single implant and you want to do it with the delayed loading concept, you need some kind of anti-rotational component attached to that. Okay, so in the bypass system, what we came up with that kind of anti-rotation. So that permitted us for delayed loading with the rough surface and the hybrid surface implant. Number one. Number two, we came up with this two-piece kind of design. It is single-piece implant in itself. Only the abutment we have split. Instead of going through the implant and widening it here, all the thing that has to be in two parts is above the gingiva. You got it? So that's the main difference. There are two differences were
Sorry, sir.
there. In
This point I just could not get. The first point is that the abutment has an anti-rotational groove, and because of
no,
this,
no,
the
not
delayed
the
loading.
abutment, the implant. The implant.
Oh, okay. The implant has an anti-rotational groove. Okay.
Component attached to it. Right. So what happened was we basically, if you delayed load a basal now, the failure is because of the rotational failure. The most common failure in delayed load, if you try to do a basal implant delay with delayed loading a single piece, so the basically the implant start
Correct.
rotating after some
Correct.
time and the implant fails. So basically we have taken care of that. Okay, number two, we have given three kinds of surfaces. Number three, we have come up with the two-piece design. Plus in the tornado implant, the minimum diameter is a 3.5 millimeter implant. Now we even have a 2.7 and a 3 millimeter implant with us. Okay, the
Okay,
two-piece
sir.
system
Okay.
is there. The abutment is in two piece. The not the implant is in two piece. The only the abutment is
Okay.
in two piece. Okay,
Okay.
with the
Yeah.
wider
Probably, sir. As we proceed in the presentation, yeah, we maybe I may be able to get the
you will
parts
get
of
to know.
this implant actually,
Otherwise, if
because
there are still any doubts left now, you can just call me up. I will let you know of my number in the end. Okay, so you can call me up and
G sir,
we'll discuss it further.
G. G
So
sir, G. Okay.
today's
Yeah,
lecture is
actually,
just a
basically
short.
the on the slide actually, G on the slide, basically the on the slide that you shared, it looks similar to BW and W.
Uh,
That's why
so that was
the
basically the
result on the
earlier
slide look.
version.
Okay,
When basically sir the original implant was the tornado which we built upon the
okay,
system. Okay, so
okay,
earlier
okay.
when we developed the three surface designs now, so then we named as a tornado B, BW and W, and later
Yes.
on we made it as a whole system in itself.
Okay, 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 sir. Fine,
You
sir.
got it now.
Please
Basically,
proceed. G sir.
at that time it was an accessory system for a limited indications. But now
G.
we have basically increased the indication and developed it into a stand-alone system. Basically, you can
Right,
use the
sir.
system alone without the use of any other kind of implant. So,
Right, right,
what
right.
advantages do we have with this system? Is number one, the flapless option is there still. A single drill protocol can be employed for most of the bones and most of the sizes of the implant. Graftless solution it still provide. Anchorage flexibility is there, which is not in the basal implants. We can either go for crestal, mid-body, pericortical or transcortical anchorages with the bypass implant system. We have the flexibility of loading, immediate or delayed loading based upon the case requirement. As I just forgot the name, Dr. Jessica said there are certain indications of when you want to delay load or when you want to immediate load the implants, right? So in basal, we don't have the virtue of choosing when we want to delay load the implant. But in this system, you can choose to delay load as per your convenience, depending upon the case, depending upon the systemic health, and depending upon the talk you get while performing the surgery. Then we still have the bendable neck that is bendable up to 45 degrees without any fracture, allowing for the prosthetic flexibility. Okay. So we have three different kinds of surface. One is the hybrid surface, that is the, as Pratish said, the BW as we call that, the black and white. It has both the surface treated part in the center and it has the smooth surface crystal threads and the smooth apex. Then we have the B as the black one. All the threads are surface treated in this design. And then we have the W, that is the smooth surface option that is there. So the smooth surface is ideal for immediate placement into the infected sites where part of the implant might be exposed. I will show you the cases in the end. I have certain some beautiful cases that will explain you well how these things are integrated in the body. It maximizes the soft tissue integration and minimizes the peri-implant risk. Then we have the hybrid surface that is for the immediate loading and the transmucosal healing because of the smooth collar and the rough mid-body thread. Biological stability with the bone and the mucosa is there. Then we have the fully rough surface thread to maximize the osseointegration. I will just tell you on my tabletop. I think I explain rather better with a paper and pen than with the screen in on my face. Mr. Jack, can you please pin my screen? It is still not pinned, I think. Mr. Jay? Yes, sir, please करवा दीजिए मैं tabletop use करना है. Just wait for a 2 minutes. Anyone has a question in between meanwhile that this is being done?
Which of
Anyone
the
has
design?
any
Yes, I have a question. Which of the design is indicated for the fresh extraction sockets? Like
fresh socket. Okay, right. So, yeah, my tabletop is not there. Just wait on a minute. So,
like
in
for
fresh extraction socket,
yeah.
verbally, I'll tell you. Can you please mute your mic? If you have anything in between, there's a lot of disturbance coming from your end. Sorry for that. Right. Thank you so much. So, sir, in fresh extraction socket, we have two options. One is the BW, that is the hybrid one, and other is a smooth surface entirely. That depends upon the active periodontal or periapical infection if that is there. If some active infection is there, we advise you to go with the entirely smooth surface design. Whereas in the case active infection is not there, or you are able to curettage the socket properly so that all the granulomatous tissue is removed properly, in that case you can go with the BW implant, that is the hybrid implant. Why? Because in the fresh extraction sockets, when using a fully threaded implant, there might be a condition in which some of the threads might be exposed because of the loss. Yes, Dr. Sajid, very good. Even I use them. So, in the fresh extraction sockets, what happened is usually due to the loss of the buccal plate, sometimes some of the threads might be exposed. So in the hybrid implant with the BW surface, that is black and white implant, what usually happens is the surface that is exposed in the socket is the smooth surface. Okay, so in that case a bone might be able to grow over that. Even if it doesn't grow, then also in that case a muco integration will happen with the smooth surface threads. Got it, Dr. Varun?
Yes, yes, I got it. Like,
Got it now?
what is the benefit of using tornado in such cases? Like, if you want to use tornado implants, your tornado
Sir,
design.
and now we have basically converted the whole of the tornado into the bypass system itself.
Okay.
Got it?
Like
So
tornado.
basically, what happens is, in an extraction socket now, we want the part that is to be exposed outside the bone. The threads that are exposed outside the bone should be smooth surface only.
Oh, 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 oh. So
Okay,
how in how many days?
Dr. Varun, please, yes, sir.
I am asking, like, in how many days you are going to load these implants? Like,
So that totally depends upon the torque you get and the type of implant you use and the anchorage you use. So this is all covered in the coming slides.
okay, okay, okay. Thank you.
Yes, my tabletop is well. Now I can answer. So basically, we have three different kinds of implants. Sorry for the drawing, everyone. I want to ask everyone enjoying the lecture or getting bored in between, huh? So one is the B, that is a fully surface treated threads. Then is the W, that is a fully smooth surface. Then there is a one that is the middle third is surface treated. So while placing the implant in an extraction socket, suppose this kind of defect is there. Okay, when I place the implant, the only thread I want out, if they are left outside now, should be a smooth, either a W can be there or a BW can be there. Okay, so what happens is, when the rough surface threads are exposed, everyone knows what happens, right? A peri-implant mucositis will be there, peri-implantitis will be there, bone loss will be there. Ultimately, the implant will fail. So, as a contingency, in those cases, we use these two kinds of design. Why? Even because if in some case, suppose this is the case, this much part is left exposed, covered by the soft tissue only. It is only covered by the soft tissue, right? What will happen is, because a smooth surface, there will be no biofilm formation. In the rough surface, there is a biofilm formation there that leads to failure of the implant. So the smooth surface, there will be no biofilm. Later on, the socket can heal to its natural state. Either the bone can form here. If even the bone does not form, what will happen is the smooth surface threads will muco integrate with the soft tissue itself. Okay, okay, Pritish. Dr. Pritish,
Ji, sir.
clear?
Yes, 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 yes.
Any other questions?
The tabletop is not visible, doctor.
My tabletop is not visible.
I can't able to see that. Where it was
Doctor, the tabletop is for some people it's in the down screen like participant side. You can search it and enlarge it.
जैसा एक मिनट देखना प्लीज प्रॉब्लम आ रही है यार. Everyone else, is it visible?
I can't see it, but that is why I was asking.
You can just refresh your screens if that would be possible for you.
Okay, let me see.
Sir, you still have the, sorry, I'm just interrupting again. You still have that tornado system and you have now developed this system, sir.
No, sir, Tornado, we have converted totally.
Well,
So if you want to use
okay,
a
okay.
Tornado, you will get the bypass W.
Yeah, yeah, yeah. Which is, jiska nomenclature is almost same as, I mean, not almost, it is same as the tornado one. The
Yeah,
white being totally smooth, surface
yeah,
treated being black, I mean, B, and then BW being a hybrid version. It's the same thing,
hybrid, combi
right?
implant type. Right.
G, G, right.
Okay, where you want to use a Tornado now, you have to use the bypass now.
Yeah, correct.
Reduce the basically to reduce the confusion in between. So that's why we entirely converted the system into the bypass.
Right, sir. Right, right.
So, any everyone, it's clear. My tabletop is visible.
Yes,
Everyone
sir. It is
else,
visible, sir. It is visible,
uh,
sir.
It's visible, sir.
for someone it is not visible. Please let me know now. And are you guys enjoying the presentation as of now?
Yes, sir.
Anyone having any problem of any kind?
No, sir. No, sir.
Any questions till now?
Sir, the tabletop is not visible to me, sir.
Sir, I think for everyone else it is visible. You can
Doctor,
just
doctor,
exit the meeting for once and rejoin if that would be possible for you.
doctor. You can go on the screen downside, scroll down. There will be the screen and type on the touch on the three dot. It will enlarge.
Okay, sir, I am trying.
Go to the participant side.
Okay, sir, now it is visible.
So this is the tornado, sorry, the bypass implant. Okay, the doctor sahab got me confused in between. Right. So what are the various advantages that we have with this system? Like I told you, anyone wants to re-enumerate the advantages of bypass implants? Dr. Akash?
Yes, doctor. Sorry, I got stuck somewhere else. I missed your question.
Okay. I just thought, can you please re-enumerate once again what are the advantages of bypass system?
Yeah, bypass implant. First is that it can be used for both immediate loading as well as for delayed loading. Second, it can be used on those cases where infection is present. But I have one question. I raised my hand. In
Yes, sir.
active infection, another
Yes, sir.
reason for us for delaying the implant was that if we
Mm-hmm.
go for the cortical, if it is periapical infection, especially not
Mm-hmm.
the mucosal one. So if we
Mm-hmm.
perforate the cortex, we'll end up with a cancellous bone. And if
Yes,
active
sir.
periapical infection is there, then there is
Mhm.
chance of that infection going into the cancellous part of the bone,
Yes,
and
sir.
that can theoretically cause osteomyelitis.
Uh,
So,
mhm.
I would still try to avoid in cases of active periapical infection like periapical abscess and all. But yeah, if it is there in the superficial part, we can definitely granuloma and other things we don't consider as infected because they are reactionary tissues. I'm talking
Mhm.
about the abscess.
Sir, abscess. So basically, as you are a oral surgeon, right?
Yeah.
So you might be frequently getting the cases with severe facial lacerations, and still the fracture is there. So, sir, with the smooth surface implants, now this kind of complications are rare if you employ the localized disinfection techniques properly. If you do the proper socket curettage and you do the betadine rinse in the socket, right? You irrigate with the betadine sequentially, diluting it till it comes to a normal saline only. In that case, na, you can avoid these complications, and the smooth surface implants, na, they don't very easily carry the infections apically if you
Uh,
employ the suitable techniques now. Sir, in my practice what I have been doing now, I have
it
been doing
depends.
the immediate loading. So there has not been no, you raise a good question.
I
You
said
raised
it is
actually
a
a good
theoretical
question, but
question.
practically it is not happening. Practically I am using smooth surface implant. I will show you a case also
Yeah,
where did the implant.
it is there. The question is, it depends on two factors as far as my theoretical knowledge is concerned. First is the bacterial load, and second is virulence of the bacteria. So if there is a bacterial load, then of course the body will take care of it. The antibiotic will take care of it. Second thing, if the bacteria is highly pathogenic, then even with a less bacterial load, it can cause. Second, somebody advised me, sorry, I got completed. somebody
Sir,
advised me to use
your
a
voice is breaking up. Sir, Dr. Akash, sorry. I think Dr. Varun, please mute your mic. Your disturbance is coming a lot of. Yes, now it's clear. Dr. Akash.
yeah,
Yes, sir, please
somebody
continue.
just now somebody advised me to use a longer implant. So
Mm-hmm.
I will still be hesitant because it is not about the length of the implant which worries me. What worries me is that the cortical bone, it acts as a barrier for going the infection to the cancellous part of the bone. And
Sir,
it,
in that case, no, you don't go till. Sir, usually
yeah, in
what
that
I
case, we can
employ.
engage the walls of the implant rather than going periapically.
Exactly. That flexibility this implant provides you. The bypass is going to provide you with that flexibility also. So that this is a very versatile implant system. You can use it as you like. I am just coming to that point only. The diameters that are available with us are 2.7, 3, 3.5, 4, 4.5 and 5. So a lot of diameters are available. You can use it to anchor socket walls also. But in my practice, I have been doing these implants for a very long time, even in infected sockets also. So I use the localized disinfection techniques properly, so that the osteomyelitis complication I haven't seen in my practice as of now.
That's why I said theoretically, because even
Theoretically,
I have used
theoretically,
tetracycline, I have used doxycycline in such cases, but it is all theoretical. In like private practice, it is a
prac-
bit difficult to venture into it. Yeah, in some adventure situation, I might be more courageous.
okay. So, sir, basically, I think you have answered the question yourself. So, in practical situation, this kind of thing usually does not happen. Never happened to me.
Again, I would like to point another thing. Like in such cases, you have mentioned that you are using inactive infection site, like these implants that you had good results with it.
Mhm.
Like I know like how much is the follow up for such cases?
Sir, for now, the longest that I have is 6 months.
6 months, okay, and
And I think that is sufficient. I think after this much time, after a few weeks, I think the infection,
Yeah,
when the
if
implant
it has
start
to
healing,
take,
I think
whatever has to happen will happen within weeks.
within
So
weeks,
later,
right?
some
and
doctors
Yes.
have the data of like 9 years.
Yes, sir. In basal, we use smooth surface implants. In infected sockets, yeah, we have a longer data in basal implants also. I'm just talking about the bypass system as itself. Okay,
Okay.
in the basal implant, the smooth surface implants are being placed in infected sockets for a very long time, decades now. So this kind of thing, I think I haven't even read in any kind of literature that infection is being transferred with a smooth surface implant apically.
okay, and another thing is like in such cases, how many days you loaded the processes?
So that depends upon the talk that I get.
Okay, so
My,
that
my, my,
doesn't.
my loading protocol is not about the infection that is present. My loading protocol is about the torque that I get. Usually, in my experience, in infected sockets, now the bone is become very soft.
Yeah, that
Okay,
is what I am
the
asking.
bone becomes very soft because of the infection, and there is a bone loss, and there is a lot of osteoclastic activity going on. So usually you don't get that kind of a torque that you can load it immediately. So you have to go with delayed loading in those cases.
Now, how much delayed loading like you usually used to do like in such cases? How
Three
many
months.
days
Three
or
months.
hours?
Sir,
Three
three
months.
months. 3 months.
Okay, both in maxilla as well as in mandible. 3 months.
Both in maxilla as well as a mandible. But sir,
Okay, and any
one other
surface.
thing comes. One other thing comes. Even suppose there is a case of an infected socket. Okay, so suppose I draw the maxillary cross section over here. This is the nasal cortical floor. This is the tooth socket, and it was infected periapically, right? So if you place the implant over here and you are able to place the implant anchoring the basal cortical, then in that case you will get a very good torque and you might be able to load the implant immediately in that case too. So that
I got
totally
it.
depends on torque. Even in the infected sockets, if you get a good torque, then you can load the implant.
And any surface decontamination also you like advocate prior, inserting in such sites.
No, sir. Localized disinfection of the sockets we advise. The implants are already surface treated properly. The implants that
No,
you
any
will get are properly.
pre-operative chlorhexidine rinses or some antibiotics like pre-op antibiotics or in such cases, no.
Sir, that you can give if you want to, but in my practice, if the infection is not a major infection, that the patient is accompanied by a lot of swelling and pus when I extract the teeth, and there is pus coming out, in that case, I don't go up with immediate implantation.
Yeah, yeah. ठीक है.
Okay, if the
That's
patient is having
thank you.
swelling, a lot of infection is there, in that case, I haven't done the implant.
Okay, okay, okay. Right. Thank you.
Okay, if there is a periapical infection without any extraoral complication is there, na, there is no swelling, there is no pus discharge. In that case, I do the immediate implant. If there is a pus discharge, sinus formation, in that case, I don't advise immediate placing the implant.
And in your cases, like complete osteofixation, it takes how many months? Like,
Osseointegration, sir, osteofixation, sir, that don't get confused. These are not basal implants. Okay, this gives you a latitude of options of fixating the implants. Okay, I'll come back to it. Then we will discuss. Let me show you the slide first.
okay.
Okay, so surface. Everyone understood what kind of surfaces we are providing. Dr. Varun, I will be just getting to it. It is already mentioned in my slide. Just I think one or two slides more. Then we'll come back to your point. Okay. So, Dr. Akash, I think when we had that
Yeah, we are on
conversation
the same
regarding
page. We are on the same page because you answered it when there is active infection, like when there is extra. That is what.
extra swelling and pus, yeah, in that
Yeah,
case, don't place the implant.
we consider that as infection, the pus discharge.
Okay, okay. When we are talking about now, I just really thought about a periapical infection forming on the
Granuloma,
roof. You take the X-ray, and
granuloma, we
there's
don't.
an
Granuloma and cyst we don't consider as infected. They are reactionary tissues.
yes, sir. Uh, Okay, someone said that he is missing the flow. So in pus discharge cases, in that kind of severe infections, now don't go for immediate. I'd never go for that. But in normal infection, is there is a abscess, or we can see on the IOPA that there is a periapical infection or a granuloma. Okay, and some kind of reactionary tissue is there. In that case, you can proceed with that. If there is pus discharge, there's sinus formation, there's extra swelling, then don't. Okay. So surface option is clear to everyone. Anyone has any question regarding this? Anyone? So
Oh, no,
basically
sir,
the
no, sir, no, sir.
okay, so the rough surface you will use when you can fully submerge the whole of the threads inside the bone. There is enough bone width present, okay, and all the threads are inside the bone. Smooth surfaces, whenever there is infection or there is a chance there is excessive buccal wall defect is there. So there is a huge buccal wall defect and a lot of threads might be exposed. In that case, go with a smooth one. And the hybrid one you will use when only there is a crestal defect. Okay, only a few of the threads at the crest might be exposed. In that case, go with this kind of an implant. So there are a lot of basically a versatile amount of dimensions, both in the terms of diameters and length that we have. We have diameters from 2.7 up to 5 millimeters for diversified need of the patients and the clinicians alike. Okay, so whatever kind of bone is there, whatever kind of width is there, what kind of density of the bone is there, so you can suitably employ the implant based upon that. And then there are the lengths that are available. These are 10 mm, 12 mm, 14 mm, 17 mm, 20, 23, 26, 29, so that the implant is usable in all the situations in every way possible. I will come back to this. Yeah, now we will come back to the main point. That is, this implants give you the versatility of using either mid-body anchorage, pericortical anchorage, or transcortical anchorage. So now I will show you with my tabletop about these kinds of anchorage. Anyone getting bored or wants me to fasten up the lecture? Anyone? I can just run through it. Dr. Akash,
यस डॉक्टर साहब।
सही
सो
चल रहा है? मैं कहा ज्यादा वो स्लो तो नहीं चल रहा?
आपको सबके हिसाब से चलना है।
So everyone, I can just follow this pace or I can just fasten it up. Dr. Mangal, Dr. Jessica.
डॉक्टर
Enjoying, sir.
जैसिका इज
Enjoying.
विद द पेशेंट।
Okay. So everyone enjoying, I think. So suppose this is the cross section of the bone. On the outside, we have the cortex. On the inside, we have the cancellous bone. Right? So this is the crestal part, the crestal cortex where the root was there earlier. And this is the basal cortex. Suppose I place an implant just like this. So, what kind of anchorage will this be called? If I place the implant only in the cancellous bone, so what kind of anchorage will this be called? Dr. Mansi, you there with us?
Mid body
Mid-body.
anchorage.
Okay, yeah. So, this is known as a mid body anchorage, just like we do in the conventional implants, right? And suppose I place a longer implant and rest it against the basal cortex, not perforating it, then what kind of anchorage will this be called?
Very cortical.
Pericortical.
Everyone has attended my lectures, I think, huh?
Yeah, yeah, yes, sir.
Pericortical. And if my drills goes through and my implant and at least one thread engages the basal cortex, then what will it be called?
Transcortical.
Trans.
Transcortical.
Transcortical. शुक्र है डॉक्टर मानसी हैं अभी साथ, मुझे लगा आप चले गए.
नहीं sir,
So Dr. Mansi is a very passionate doctor. She has done a course of basal implants with me. So I really love to have my older students with me for these kinds of webinars. So it's clear when I am only using the cancellous bone, like in the two-piece implants we do, that's the mid-body anchorage. When I rest my implant on the basal cortex, it is known as pericortical anchorage, and when I go through, it is known as the transcortical anchorage. So
The
with
screen
this
is
kind
not
of
visible.
length, what sir?
The screen is not visible.
Everyone else, the screen is visible. Yes, sir. Everyone else,
yes,
it's
it is
visible.
visible.
Which one, sir?
My tabletop is my tabletop. This one
Which one, sir?
The tabletop is
visible.
not visible.
Visible.
Sir, there's a problem with you. You can just you can just end the meeting and come back again. I think then it would be visible for you. Okay. So with the diversified lens that we have, okay, we have 10, 12, up till 29 mm. So you can deploy any kinds of anchorage that you want with this, depending upon the density of the bone and the quality of the bone and other factors that you can consider. You can either use it as a simple two-piece implant, or you can go a little bit deeper and rest it as a basal cortex like we do in all on 4 and all on 6 sometimes, and either you can use it as a basal implant and engage the basal cortical bone actively. So that's the advantage of the lens so many that we are offering to you.
So does this mean that it is like a basal implant and and a conventional both,
Ma'am,
or
exactly
it
that
does
is what.
it only
All our implants will osseointegrate. Okay, so the story, how the story begins. The story begins from the day 0 till the third month when the osseointegration happens. Okay, so if we want to do the immediate loading, right? So we need immediate fixation. We need immediate load bearing capacity of the implant to be there, right? So that can be on either day. Basically, what I mean was the implant should be with the high primary stability,
So
right?
in case
For
of
it to
immediate
be
loading, it would be, in case of immediate loading, we can work as like we can do the fixation thing like in the
ma'am,
basal implant.
like in the basal implant, if you want to, you can. But even if you get the torque in mid body, now I will show you the cases where I get the torque in mid body without even going near the basal bone. So in that case also, you
Okay.
need a good torque. Just like the conventional implants, you need a torque that is greater than 35 ncm. If it is there, load it.
Okay. Okay. All right. Yeah.
Okay, irrespective of the type of anchorage that you employ, irrespective of that, you can load it with a PMMA crown. Okay,
All
not
right.
with the definitive prosthesis. So we strongly recommend, even if you are using it with immediate loading, any of the implants, do it with a temporary crown. Initially, a PMMA one. You can use it as long as you want. Okay, and you can, if you want to change, you can change them after a period of 3 months.
All right.
Okay,
Okay.
if you want to use, like in my cases, I have been using the PMMA crowns for 1 year or 2 years, maybe even, till they are functioning and there is no problem with the patient aesthetically, or there is no problem with the food lodgement. I just give them as a definitive prosthesis only. They last between 2 and 3 years sometimes. Okay, so till they are lasting, they are good. So there is no problem with that. Okay, so that's the versatility of the system, that you just need a good amount of torque and we can help you achieve in any way that is humanly possible in the dental implantology. Okay, with the mid body also, with the pericortical also, with the transcortical also. You need just the implant to be stable for the immediate loading. Got
Yes,
it?
understood.
Any other questions till now? This is clear, everyone? Yes, sir. Splinting. Someone asked the question: is splinting possible? Yes, splinting is possible. You can do the intraoral welding, or you can give an intraoral casted frame with that.
तो सर इसमें होगा क्या, ऑस्टियो इंटीग्रेशन रहेगी, ऑस्टियो फिक्सेशन होगी, यही नहीं समझ में आ रहा मेरे को तो।
अच्छा सर, ये प्रॉब्लम आ रही है आपको?
हाँ, ये
सर
बहुत बड़ी।
बेसिकली देखिए, फॉर द इम्प्लांट फॉर द इम्प्लांट टू ऑस्टियो इंटीग्रेट, इट नीड्स हाई प्राइमरी स्टेबिलिटी। ठीक है, ये आपको आप कैसे भी ला सकते हो। ये आप मिड बॉडी में भी ला सकते हो, ये आप पेरिकॉर्टिकल में भी ला सकते हो, ये आप ट्रांसकॉर्टिकल में भी ला सकते हो। When you go transcortical, this is known as osteofixation. You just need the primary stability for a period of 3 months. Okay, got it. So either way you can have it, depending upon the case to case basis, depending upon the bone density, you can select. If you get a soft, sir, Dr. Varun, please mute your mic. If you start drilling and you have a very soft bone, very soft, you go pericortical or transcortical. Okay, so that the basically osteofixation is only one of the means for primary stability. It is only one of the means. It
दैट
is
मीन्स
not the only mean. Like in basal, it's the only mean that is there so that you can integrate the implant inside the body. Here, you can employ this as one of the means to get the primary stability so that you can load your implant immediately if you want to. If you don't want to immediately load the implant, if there is soft bone, just leave the implant for delayed loading, even in the mid body case. Dr. Varun, it's clear?
या, तो दैट मीन्स यू कैन हैव both types of loading in these kind of implants, right?
Exactly, exactly. So depending upon the case complexity, you can just figure it out for yourself that you get the primary stability or not with the mid body, or you with when you are drilling now, you come to know with the density of the bone with tactile sensation. Like Dr. Akash and I have a very had a very good discussion about a tactile sensation that we have. Okay, so if you can do good tactile sensation, you can just feel that where you get a good anchorage, and there you can place the implant. If you don't want to immediate load them, you can just always go with the mid body like the two piece implant. Okay, Dr. Varun.
Yeah, sure. Thank you.
No, if there's still any doubt, I will answer that. There's no problem with that,
Okay, okay, right. तो
right?
तो अभी कुछ होगा, like I will ask you like subsequently.
Dr. Krishna Kumar has raised the hand. Dr. Krishna Kumar, you want to ask a question?
Yes, sir. I would like to ask a question.
Yes, sir.
So, in case of delayed loading,
Mm-hmm.
so how the abutment can be maintained till that time? Because it's a single piece implant, no?
Yes, sir. It can be left as it is. It will act as a transgingival healing collar, healing abutment.
Okay, it
You
may
just
come
need
in
to set
contact
it
with
out
the
of
opposite,
occlusion.
arch. Yeah, out of arch. Okay. It may come in contact with the opposite arch, opposite
No,
teeth.
that we
There
don't
might
want.
be.
Then it's immediate loaded now. We don't want it to come into contact. That is required with this implant system.
Okay. That may if it come in contact with the opposite teeth, no, there will be the micro movements will be there, no?
Yeah, then in that case it will be there.
Can you give a temporary coping in such cases?
Yes,
Like,
sir. We will provide that with you. Okay. Basically, sometimes usually it does not happen because titanium is a poor conductor of heat. Okay, so sometimes it happens that a patient might complain that he is having a sensitivity to hot and cold with the implant site is there. Okay, in that case, now we will provide a coping with that, so you can use it as a healing cap over the exposed abutment inside the patient's mouth. So that will be provided along with the system.
okay, so after 3 months, if you can again check the situation, like whether the loading is
Implant has
good or
integrated or not exactly, and then you can load it just like a two piece.
just like a two piece.
So that's it. That's the fun of the system, na. It gives you all the advantages of both the worlds. Okay, so you are. I think a majority of you, every one of you, are doing two-piece implant. So you don't need to learn anything new with this system, and still you get all the advantage of basal system without going to the basal bone. Got it? All the flapless surgery, graftless surgery, everything will be there without a bone grafting, and still you can use it as a two-piece system.
So, do you advocate sin crystallization with these implants?
Sir, I have been doing this for a past few cases.
So, do you advocate sin crystallization with these implants?
Sir, I don't basically advocate anything as of now because my experience with synthesization is very limited to advocate for something.
No.
Because let me tell you what I am doing is because for the bypass system now, for gathering up the case studies and case histories of publication, we are doing a lot of patients for free.
Okay.
Okay. So in that case, the prosthesis that I usually do is of a titanium bar and a PMMA overdenture over that.
Yeah, that is what I am
So,
saying. Na? Like,
that is not viable for doing the patients for free because we get those made for at least 35-40,000 for a pair for upper and lower, right? So for that cases now we have been the recent cases that we are doing for free for the bypass now we are doing it with the synthesization and the acrylic overdenture.
in most of the basal pundits, na, they usually advocate that it is better to err on the safe side. Do sin crystallization with every case, full mouth cases. You
Sir,
know,
basically, sir, I will be able to tell you after 6 months. Okay, then I will be better tell you because I don't know what the results will be.
I also don't have any experience with sin crystallization. Basically, I don't have any experience with basal implants only. So that is what I am asking, because you had put 2,000 implants. That is what I am saying.
So,
So
sir, till I started doing this bypass system, na, I didn't do any kind of skin crystallization in basal. Okay, even in the initial bypass implants, also, I did not go for any kind of syncrystallization. But now we have to bulk up the cases, right? We are planning to do 100 cases in the next 6 months with a bypass implant so that we can do these studies and publish these studies in the reputed journals. So, for that, now, for the cost point of view, we are doing that. So, I may be able to tell you with my experience that if it works good or not, the synthesization part remaining the as of now I prefer to go with the bar and overdenture type of thing.
And for single tooth restoration, PFM can be given.
Sir, in the basal, no, sir. Basically, I prefer going with the PMMA, the soft loading protocol for the initial period, and with the metal acrylic you can give. Metal acrylic you can give, a PMMA you can give.
Okay. No, no, I am
Okay,
asking
but
for the permanent processes. Which permanent processes you advocate?
sir, the permanent prosthesis you can either give a PMMA.
So
I
that
give
would be
PMMA as permanent. The milled
feasible.
PMMA, the milled one.
No, no, that
The
would be feasible for the full mouth cases, na PMMA.
Sir, I even give the PMMA for a single tooth also. Even mine, na, this one is a PMMA. I
Okay,
did my own implant.
okay,
This is a cross implant, okay, and this is
okay,
still a PMMA. I have been using it for a year now.
okay. So, matlab like for permanent restoration also, like you are going to like give PMMA.
I do, yeah.
So, won't be it having some long term complications of staining or fracture or
So, sir,
adhesion?
sir, sir, PMMA are of two types. One is a milled PMMA and other is a resin printed PMMA.
Hmm. So, which one you advocate? 3D printed,
Milled one.
milled one.
Like just like zirconia, there is a block of PMMA and you mill that. So in this na there is no problem of leaching. There is no leaching of uncured monomer in that. There is no problem of staining. I have that one there. It has not stained in a year.
Okay. No, no. I am not saying of a leakage of monomers or something else. I am asking for the long term complications of the
Sir,
equipment.
long term, so I just tell you, long term you can give a PMMA, long term you can give a PFM, long term you can go even give a zirconia over it.
Now, that is what I am asking. Now, you can give PFM and zirconia also.
Anything, anything.
Okay. And for full mouth cases, only PMMA. Hybrid.
Sir, I do PMMA and I do zirconias also for full mouth.
Okay, okay. So that means
I
you can.
never do PFMs.
Okay, 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 okay.
For full mouth, I don't do PFM because there's a problem chipping of the ceramic from the metal now.
Okay, okay, okay. So either you give PMMA or either you give zirconias.
Zirconia, exactly.
Thank you. Thank you so much,
Because
doctor.
in zirconia there's a problem of chipping now. The repair is comparatively easier.
Which kind of zirconia you advocate? Monolithic only?
Sir, in a full mouth case, I go with monolithic only with the layered anterior.
Okay, layered interiors. Okay. And you are going to give screw retained restoration or like the cement retained for that?
So both of them I give.
Both of them you give. Okay. And okay. And per tooth, like for single central incisor, how many
Single
implants?
implant. Single implants are just like conventional. Single implants, sir, I have done all on four and all on sixes with this implant.
Okay, okay, okay. Okay, so
I
that
have
means
done all on four and all on sixes with this implant.
so that
I'll
means
show you a case. I'll show you a case.
okay, 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 okay.
Sir, if you don't mind, can we keep the questions for the end?
Yes, sir, we can.
It just breaks like the continuity.
So surgical loading and decision making. So the optimizing stability and loading decision. So we basically try to use a longer implant whenever possible to reach the cortical bone, but it is not necessary. If you want to use that, you can. If you don't want to use that, you may not. Okay, and basically the benchmark is the of the primary stability is a torque. Okay, if you get the 35 to 45 NCM torque, go with the immediate loading. Okay, if in the mid body there if you get a torque less than that, go with the delayed loading, right? And when you are doing the mid body anchorage only, go with the soft PMMA crowns or non functional loading only. If you, even if you get the torque, only use the PMMA for an initial while. Okay, later on convert to the definitive prosthesis. Okay, only temporary prosthesis in the beginning, whatever be the case, if you are doing the immediate loading, right? And later on, you can change that prosthesis to a definitive prosthesis as per your liking. And sometimes I give the PMMA crowns, they work well. I leave them as a definitive or long term provisionals also. Like I am using mine one for a year. When it goes, then I will replace it with a zirconia. Till then it's functioning well. It may last up a year, for 2 years or 3 years, maybe even more than that, because I use a very good quality PMMA blocks for my milling. These are basically carbon fiber reinforced PMMA blocks. Okay, if anyone wants the exact brand name, just let me know. I will also let you know the brand name also, so that you can tell them to your lab and they can arrange these blocks for you. These are graphene reinforced PMMAs. Immediate versus delayed protocol. Okay, I think it's clear. I will skip through that. It's clear to everyone. Na? Still anyone has question regarding the loading? Dr. Varun, it's clear. Dr. Akash, it's clear.
Yes, yes, definitely. Thank you, doctor.
Dr.
Yes, sir.
Akash.
Yeah, of course, yes.
सर
Okay, then we come to the yes, sir.
मतलब कहने का ये है सर कि हम इम्प्लांट प्लेस किए और कन्वेंशनल के जैसा इसको छोड़ सकते हैं क्या, बस 15-20 दिन के लिए?
15-20 दिन के लिए सर, जो आप हमारा नहीं 15-20 दिन बाद लोडिंग कर देते हैं।
नहीं, सपोज 3 महीने के लिए छोड़ सकते हैं क्या, लाइक
हाँ,
कन्वेंशनल?
आप छोड़ सकते हैं सर इसको 3 महीने के लिए। ओके सर, मैक्सिमम लोडिंग जो डिलेड मैंने करी है ना, सॉरी इमीडिएट मैंने करी है मैक्सिमम टाइम के अंदर, वो मैंने 2 हफ्ते के अंदर करी है। प्रेफरेबली ये गलत है। प्रेफरेबली आपको प्रोस्थेसिस पहले 3 दिन के अंदर देनी होती है। लेटेस्ट टू लेटेस्ट, इफ यू आर यूजिंग अ रफ सरफेस इम्प्लांट और अ हाइब्रिड इम्प्लांट, वो आपको जो प्रोस्थेसिस है विद इन अ वीक देनी होती है। मैंने 10 डेज डिले करके देखा है, मैंने 15 डेज डिले करके देखा है, उसमें मुझे कोई प्रॉब्लम नहीं आई। उसके बाद का मैंने ट्राई नहीं करा, एंड इट इज नॉट एडवाइजेबल। अगर आपने पहले 10 दिन वाला बेंच मार्क क्रॉस कर दिया है, देन वेट फॉर 3 months फॉर लोडिंग। Don't disturb the implant in between the healing.
सर बेसल में सिंगल पीस इम्प्लांट में कोई भी ऐसा नहीं बोलते कि इतने दिन के लिए छोड़ सकते हैं।
ये बेजल नहीं है ना सर। सर नॉट ऑल सिंगल पीस इम्प्लांट्स आर बेजल, आप ये बात समझिए। ये कन्वेंशनल इम्प्लांट है। हमने सिर्फ चेंज क्या करा है, हमने लेंथ ज्यादा दी है आपको, ताकि आप इसमें और तरह की एंकरेजेस ला सकें। हमने डायमीटर्स बहुत तरह के दी हैं, नैरो और वाइड, ताकि आप हर सिचुएशन में इसको यूज कर सकें। हमने सिंगल पीस दिया है आपको, ताकि आप इसको बेंड कर सकें, एंड आपका माइक्रो गैप खत्म हो जाए। यहाँ पर आपको सिंपल प्रोस्थेसिस मिले, आपको नैरो जंक्शन मिले, जिससे कि बोन ग्राफ्टिंग ना करनी पड़े आपको।
बट सर स्मूथ
ये बेजल नहीं है। ये
बेसल में
बेजल नहीं है। ये बेजल है ही नहीं।
ये तो बहुत
लाइक आई
अच्छा
यूज टू टेल, ये बेजल है ही नहीं।
डिजाइन, फिर बहुत बढ़िया है ये तो। मतलब इसने तो ओमिट ही कर दिया 2 पीस सिस्टम को, जो कन्वेंशनल है उसको।
एग्जैक्टली सर, तभी तो हम लेके आ रहे हैं इसको। ये बेजल है ही नहीं, इसको बेजल मत सोचो। इसको आप बेजल कॉर्टिकल को एंकर करने के लिए यूज कर सकते हो, वो आपकी मर्जी है, बट ये बेजल नहीं है। ये उस
इसमें
पर डिपेंडेंट नहीं है।
लेंथ कितनी है आपके पास? लेंथ क्या क्या है?
सर मेरी स्क्रीन विजिबल है।
10 से 29 तक है सर मेरे पास। सर एक क्वेश्चन और है, तो
सर ये
फुल्ली स्मूथ,
स्क्रीनशॉट ले लीजिए प्लीज। यस सर।
ये सर स्मूथ सरफेस इम्प्लांट को भी छोड़ सकते हैं?
एग्जैक्टली मैंने छोड़ा है।
बस मुझे यही नहीं डाइजेस्ट हो रहा है सर।
सर आप छोड़ सकते हो। सर बेजल इसमें आपको एंटी रोटेशन मिलता है, आप कभी करके देखिएगा। द टॉर्क एट यू इंसर्ट दिस इम्प्लांट ना, इसका रिमूवल टॉर्क ज्यादा होगा उससे। यू स्क्रू इन एट 35, रिमूवल 40 पे होगा। यस सर। सर जो ब्रांड मार्क का ओरिजिनल इम्प्लांट था, वो स्मूथ सरफेस इम्प्लांट था। आपको ये पता डॉक्टर मंगल?
ये सर मेरे भी बहुत से केसेस में अपने देखे स्मूथ सरफेस भी ऑस्टियो इंटीग्रेट करता है,
सर
बहुत
करता
नहीं
है
होता।
सर, एग्जैक्टली सर, बेसिकली प्रॉब्लम विद द बेजल इज, सर प्रॉब्लम नहीं है, बात समझे, बेजल आई एम ए वेरी बिग फैन ऑफ बेजल, मेरी रोजी रोटी रहा है बेजल। मेरे पास आज जो भी है ना, आज जो भी है, मतलब लिटरली बता रहा हूँ, मेरा घर गाड़ी जो भी मेरा बैंक बैलेंस है, वो सारा 90% बेजल इम्प्लांट के कारण है। ठीक है, मैं बेजल को मंदा नहीं बोलता, बेजल बहुत ब्यूटीफुल साइंस है। ठीक है, बट पॉइंट इज उसके साथ में जो नए डॉक्टर्स, बिकॉज मैं ट्रेनर हूँ, I am also an academician. I am actively involved in research and development of new kinds of implant because of Jaisar and the Bone Anchor company. I have been in the, मतलब मुझे सौभाग्य मिला, मुझे मौका मिला ये सब चीजें करने का। I just think of an implant कि सर ऐसा होना चाहिए, Mr. Jay makes one, sends it to me, I place them on the patient and I see where it goes. मैं जो सोचता हूँ सर बना देते हैं। ठीक है, तो बिकॉज आई एम एट लग्जरी ऑफ दिस, आई हैव बीन एबल टू एक्सपेरिमेंट विद लॉट ऑफ थिंग्स। सो ये एक्सपेरिमेंट्स, ये सब चीजें अपने को यहाँ तक लेके आई हैं आज कि वी आर एबल टू प्रेजेंट दिस बाईपास सिस्टम टू यू। राइट, तो सर स्मूथ सरफेस इम्प्लांट को आप छोड़ सकते हो, मैं छोड़ रहा हूँ, बहुत फ्रीक्वेंटली छोड़ रहा हूँ, वो ऑसियो इंटीग्रेट हो रहे हैं, बहुत ब्यूटीफुली ऑसियो इंटीग्रेट हो रहे हैं, बहुत अच्छा फंक्शन दे रहे हैं मेरे को। जो सर बेजल इम्प्लांट्स हैं वो आपका ऑसियो एडेप्टेशन पे डिपेंड करता है। उसमें क्या है, आपको इमीडिएट फंक्शनल लोडिंग चाहिए रहता है ताकि आपका इम्प्लांट ऑसियो अडेप्ट कर सके। उसमें थ्रेड थोड़े हैं और आप एक पर्टिकुलर सेट ऑफ बोन को पकड़ रहे हैं, बाकी बोन को यूटिलाइज नहीं कर रहे आप। तो इसलिए वो ऑसियो अडेप्टेशन के लिए आपको इम्प्लांट को लोड करना रहता है, इसके अंदर ऑसियो अडेप्टेशन इज नॉट रिक्वायर्ड। ओके डॉक्टर मंगल।
सर ये चीज मतलब पहले तो मुझे यही देख के लग रहा था कि इस इम्प्लांट से हमें फॉल्स टॉर्क बहुत मिलेगा, ये बेसल में जाने से पहले ही टॉर्क अचीव हो जाएगा, बट
सर
लेकिन आप
आप
बोल।
बात समझिए ना, आप एक मिनट बात समझिए सर, हाँ बोलिए प्लीज बोलिए, मैं टेबल टॉप ऑन कर लूँ, आप कंप्लीट कीजिए अपना। यार एक मिनट रुको प्लीज, मेरे क्वेश्चन पूछना है एवरीवन, बहुत इंपॉर्टेंट क्वेश्चन है। शैल आई कीप दिस क्यू एंड ए फॉर द एंड, कि आपको अभी आंसर्स चाहिए इसके?
Sir, I think you should actually proceed with the completion of the presentation. उसके बाद लास्ट में हम लोग अपना डाउट्स वगैरह पूछ लेंगे तो दैट विल बी
डॉक्टर
बेटर।
मंगल आप ये क्वेश्चन नोट करके रख लो, मेरे को ये क्वेश्चन पूछना जरूर प्लीज आप एंड में। आपने क्वेश्चन क्या बोला था, एक मिनट वापस रिपीट करना, मैं नोट कर लूं। फॉल्स टॉर्क, फॉल्स टॉर्क, मैं आंसर करूंगा इसको। आई लव दिस क्वेश्चन, ये मेरे साथ पहले ही पूछा गया। आई प्रेजेंटेड एक्चुअली द बाईपास सिस्टम इन अ कॉन्फ्रेंस इन जलंधर, वो 2 पीस फेलो की कॉन्फ्रेंस थी, वहां पर मैं बाईपास सिस्टम लेके गया था, तो आई गेट दिस क्वेश्चन एंड ये मतलब मैंने बहुत सुटेबली आंसर किया, तो आई हैव द आंसर फॉर दैट। So for now, this is the dimensions that are available. You can take a screenshot 10, 12, 14, 17, 20, 23, 20, 29. And all these dimensions are from the base of the abutment, just like in the basal implants are there. Because ये implant हमें flapless करने हैं, जो implant की length है, वो हमारे base of the abutment से है। Clear?
क्लियर।
Immediate loading, delayed loading, clear सबको? म्यूको इंटीग्रेशन, सो बेसिकली द वन पीस डिजाइन, इसमें हमारे को एडवांटेज क्या रहता है, द सॉफ्ट टिश्यू कॉलर दैट इज emerging आउटसाइड द जिंजिवाना, वेदर यू डिलेड लोड इट और वेदर यू इमीडिएट लोड इट, उसके अंदर बिकॉज ऑफ द हेमिडेस्मोसोमल कनेक्शंस म्यूको इंटीग्रेशन हैपेंस, जस्ट लाइक द कंसेप्ट ऑफ वन abutment one time concept. Okay, so mucointegration is happening with these implants, so this forms a very nice soft tissue collar around the implants, right? And that basically serves to protect the threads of the implant during the functional life of the implant. Okay, so you can use the implant in any kind, how much time, so 3 months only. I load the smooth surface after 3 months also.
Dr. Gagan, I have a small doubt,
Yes ma'am.
just a small surgical doubt.
Yes
What
ma'am.
about the smooth surface that we have, the portion that will remain transgingival? Is that height also variable? I
uh,
mean, depending upon the kind of gingival biotype that we'll have. What if that collar remains outside, and then there'll be a gap between the cap and the gingival area?
Ma'am,
I'm just
let
visualizing
me
what if that
let me,
happens.
ma'am, I will just let you know. Let me just write the question. Okay, tissue length.
I hope I'm clear in what I'm saying, because
Ma'am,
I've not used the implant.
absolutely clear. Basically, what we have protocol for that too. We have protocol for them. Today is just an introduction about the system, right?
Okay,
And I will
okay.
answer that question. I will answer that question. Just let me complete. So you can use this implant in any kind of indication. Okay, whether the patient is infected, whether he has diabetes, whether he has any other condition, whether the patient is smoker, whether it's an atrophic jaw, knife edge ridge, full arch case, single tooth case, immediate loading, delayed loading, anterior maxilla, posterior maxilla, for pterygoid, for nasal cortical anchorage, posterior mandible, for nerve bypass, for lingual cortical engagement, above the nerve, below the nerve, side the inside of the nerve, any way you can place the implant. Contraindication only blanket contraindications are there जो सारे जो they are there for every kind of implant. Okay, uncontrolled systemic disease, bisphosphonate treatment, severe bruxism, you have to place multiple implants, splint the case carefully, and you have to give a night guard for the patient for a full mouth case na, so that they don't break the implants or damage the prosthesis. Extremely aesthetic zone with a very high smile line, you have to use this implant with a caution. Or insufficient intra space for the abutment, because abutment is a single piece abutment. Okay, in that case also you can, in cement retained prosthesis you have to be careful, whereas screw retained prosthesis can be given in as small as a 3 millimeter inter arch gap. For the cement retained prosthesis, the inter-arch gap should be minimum 5 millimeters, just like the conventional one. Whereas in a cement retained, in conventional, it is a 2 millimeter gap is required inter-arch, whereas in our case, a screw retained, a 3 millimeter gap would be required. That's the difference, because we have placed the multi-unit above the level of the gingiva, right? So there is a small collar of 1 millimeter, so that's why we have to accommodate at least 1 more millimeter as compared to the conventional implants. There is a that difference in screw retained prosthesis. Okay, Dr. Jessica.
Yeah, thank you, Dr. Gagan. Thanks.
So prosthetic workflow is very simple. One piece implant, no second stage surgery, bendable neck up to 45-degree. Okay, direct close stage impression you can take. With the screw retained, you can have the option of closed tray as well as the open tray if you want to. Okay, and light occlusion early, as I said to you, either use deoccluded prosthesis or a PMMA prosthesis to be on the safe side when immediate loading, and definitive prosthesis after healing, that is a period of 3 months. Okay.
Yeah. Dr. Gagan, do you advocate immediate loading with these implants?
Yes, I do, sir, immediate loading with these implants.
So, in I am asking
Sir,
this.
that totally depends. Sir, that totally depends upon the torque value. Just
No,
as
no,
in
that is
conventional
okay.
implant.
I got your point, but I am asking you for immediate loading cases, in how
Mhm.
many days you advocate for to give permanent processes for such
Sir,
cases?
preferably you should give them in 3 days. On a
3 days.
scientific basis, if I answer, you have to give within 3 days, because after 3 days, bone remodeling starts.
Yeah, that
Okay,
is what I am
and then
asking.
we should not disturb. But I have delayed it up till 2 weeks.
So
I have
that
done that. It is not advisable. I am not advising that. I am just saying you, I have done that. Don't just take it for that I have said. You can delay it at least 1 week to be on the safe side.
so that means early loading. You had done early loading. Okay, right, right.
Okay, for from a scientific point of view, if you are using a rough surface or a hybrid surface, load it within 7 days. That is safe, scientifically proven.
Okay, right. Thank you.
Sir, without rigid fixation,
What's
without rigid fixation,
the full mouth or a single?
both.
So single tooth, we don't need to rigidly fixate that, okay? And in the full mouth cases, I do rigid fixation. Earlier, I used to do it with the casted or a milled titanium frame, and now I am doing it for the patients that are we doing for the case study for free. In those cases, I am using the intraoral welding. For the cases that are paying me for my clinic's personal cases, for that cases, I am doing that with the frame only.
Okay, sir.
Okay, so we have a strong preference for splinting restorations during the healing phase in the case of full arch restorations. For single tooth, there is no need of splinting. So why bypass? It's graftless, flapless, immediate or delayed, it's predictable. It combines the basal implant strategic principle with the root form osseointegration implants. It eliminates the micro gap, reduces the peri-implantitis risk. It empowers the clinician across the full spectrum of simple to extreme cases. So it's basically like Dr. Varun said, हमने तो काम ही खत्म कर दिया टू पीस का. So it's the basically next logical step in the evolution of root form implants. Just because यार मेरी बात सुना ध्यान से, just because ब्रैंडमार्क ने टू पीस implants बनाए थे, इसका ये मतलब नहीं है कि टू पीस implants ही implants होते हैं. Okay, get out of the mindset of the brand mark. Immediate loading is being done across nowadays, even in the conventional implant. So अगर आप immediate loading कर रहे हैं, so आपको क्यों अपना abutment जुड़ा हुआ चाहिए, sorry, detach चाहिए, क्यों नहीं आप जुड़ा हुआ abutment मांगते, क्यों माइक्रो गैप दे रहे हो पेशेंट्स को आप, क्यों उनको रिस्क पे डाल रहे हो, क्यों बोन ग्राफ्टिंग कर रहे हो, क्यों फ्लैप ओपन कर रहे हो आप सब. जरूरत नहीं है उस चीज की. There is no need for letting the patient undergo with so much tragedy in their lives. They are paying you for the comfort that you may provide. तो उस रास्ते जाने की जरूरत नहीं है. ब्रांड मार्क ने कर दिया, उस टाइम पे वो सही था, उस टाइम पे वो चीज ठीक थी, उस टाइम उसको नहीं पता था, उनके पास एक साइंटिफिक लिमिटेशन थी. क्यों? वो फर्स्ट कमर था. ही वॉज द फर्स्ट वन. उसके कंधों पे दार मदार था ये साइंस को प्रूव करने का, बिकॉज ही ट्रस्टेड इन इट सो मच. अब वैसे ही हमारे बोनेंकर के कंधों पे दार मदार है टू प्रूव दैट कि आपको वन पीस से काम चल जाता है, टू पीस की कोई आवश्यकता नहीं है. अब ये जो ब्रांडमार्क वाला वो था, वो हमारे उस पे कंधों पे टू पीस प्रूफ करने का था, डिले सॉरी उसके कंधों पे था टू सबमर्ज हीलिंग प्रूफ करने का, which has already been an established method that transgingival collars provide you sufficient micro movements के against protection. कोई आप अगर occlusion में नहीं है, इतने micro movements नहीं आते हैं. It has already been proven. So why still two piece? नाउ अब ना फ्रेंड्स, आई थिंक बहुत ज़्यादा टाइम हो रहा है, तो मैं अब पहले आपको कुछ केसेस दिखाऊंगा, उसके बाद में मैं आपको पेपर दिखाऊंगा, रिसर्च पेपर्स जो इन इम्प्लांट्स के ऊपर अवेलेबल हैं हमारे पास में, जो स्टडीज अवेलेबल हैं दैट इज ऑलरेडी बीइंग पब्लिश. देयर आर सो मैनी स्टडीज दैट आई हैव ओके इन माय कलेक्शन, सो आई वांट टू रीड दिस ऑल टू यू इफ योर टाइम वुड परमिट. सो दिस वाज द केस in which I have done an all on 6 with these implants. One implant was already there. Okay, I haven't removed that implant. This implant is in a lingual cortical engagement, and the anterior four implants are just like in an all-on-4, tilted.
डॉक्टर साहब इसमें
And
तो
I
मेरे ख्याल
bent.
से सिन क्रिस्टलाइजेशन हो रखी है शायद.
हाँ सर, मैंने वही बोला आपको, जो केसेस हम इसमें कर रहे हैं अभी रिसेंटली बाईपास के लिए, उसमें सिंप्लिसिटाइज कर रहे हैं हम. सर मैंने डॉक्टर वरुण, मैंने मना नहीं कर रहा आपको, मैं सिंप्लिसिटाइजेशन नहीं कर रहा. आपने कहा था मैं एडवोकेट करता हूँ कि नहीं करता, तो मैंने अभी रिसेंटली यूज करनी शुरू करी है, तो मैं एडवोकेट नहीं कर सकता, बट फॉर नाउ ये ठीक काम कर रही है.
तो इसके बिना भी कर सकते हैं काम.
सर आप बाहर के साथ कर सकते हैं, मैं करता रहा हूँ बाहर के साथ में काम.
ठीक है, बार के साथ हो सकता है ना, बस दैट इज व्हाट.
सर होता है. सर मैं इनफैक्ट अब जो नए वाले हमारे आ रहे हैं, आने वाले पेशेंट्स हैं ना, तो उनके अंदर हम विदाउट स्प्लिंटिंग भी लोड कर रहे हैं, जस्ट विद एन एक्रिलिक प्रोस्थेसिस.
अच्छा.
मैं
तो
वो भी
बढ़िया
ट्राई कर रहा हूँ। तो सर वही बात है, जो चीज, डॉक्टर वरुण प्लीज म्यूट योर माइक।
हाँ
तो सर अब बात ये है कि जो चीज मैं प्रूव नहीं कर सकता, मैं आपको नहीं बोलूंगा आके, राइट, ठीक है, बिकॉज आई एम ऑन अ स्टेज। मैं गलत साइंस प्रोपोगेट नहीं कर सकता। आई हैव अ नेम टू मेंटेन, आई हैव अ नेम टू ब्रिंग फोर्थ इन द वर्ल्ड, राइट। मुझे नाम बनाना है, नाम मेंटेन करना है, नाम चलाना है। आई एम हियर टू क्रिएट ए लेगेसी विद यू ऑल, राइट। सो मैं कुछ ऐसी चीज आपको नहीं बोलूंगा जो काम नहीं करती, मैं गलत चीज नहीं प्रमोट करूंगा। तो जब मैं सिन क्रिस्टलाइजेशन इनफ कर लूंगा, मैं इनफ उनको देख लूंगा लॉन्ग टर्म के अंदर, देन मैं आपको बताऊंगा वो अच्छा है कि नहीं है, ठीक है। बट अभी हमारी लिमिटेशन है, लिमिटेशन ये है कि मुझे बहुत सारे केसेस करने हैं, और मुझे उनके, मैं उनसे चार्ज नहीं कर रहा हूँ, मुझे केस स्टडीज चाहिए पब्लिकेशन के लिए। तो मैं अपनी कॉस्ट से एक सर्टेन अमाउंट ही अपनी पॉकेट से निकाल सकता हूँ फॉर दी स्टडीज। मैं पर पेशेंट 40,000 की केस स्टडी अफोर्ड नहीं कर सकता, कोई भी नहीं कर सकता इनफैक्ट, राइट, बिकॉज वी आर नॉट गवर्नमेंट फंडेड, वी आर प्राइवेटली फंडेड ऑर्गेनाइजेशन। हम एक प्राइवेट कंपनी है जो कि वर्क्स फॉर प्रॉफिट, बट स्टिल वी आर डूइंग द रिसर्च, सो द ऑल द एक्सपेंसेस ऑफ द रिसर्च इज बॉर्न थ्रू द कंपनी एंड माई पॉकेट, राइट। मैं टाइम दे रहा हूं अपना, तो उन केसेस के लिए हम स्प्लिंट करके प्रोस्थेसिस दे रहे हैं, राइट। बट स्टिल वो लॉन्ग टर्म में क्या रिजल्ट देती है, स्प्लिंटिंग जो इंट्राओरल वेल्डिंग है, वो भी अभी मैं नहीं बता पाऊंगा आपको, लेटर ऑन आई मे बी एबल टू टेल। बट जो पाइपलाइन में है वो ये है कि हम स्प्लिंटिंग कर रहे हैं विद फ्रेम, विद वायर हम स्प्लिंट कर रहे हैं, इंट्राओरल वेल्डिंग, एंड हम अनस्प्लिंटेड भी दे रहे हैं। Yes, Dr. Sajid, you can use a cast bar prosthesis. I have done those cases. So here you can see.
इससे अच्छा अगर आप फुल माउथ का मतलब अगर जैसे एक पेशेंट कर रहे हैं तो उसमें आई थिंक यू कैन आल्सो गिव ए फुल आर्च मेटल ट्रायन जो होता है उसके ऊपर भी आप दे सकते हो।
सर आप पी, हाँ सर, वो उनको हाइब्रिड बोलते हैं, मेटल एक्रेलिक प्रोस्थेसिस, वो हम दे सकते हैं।
मेटल एक्रेलिक पीएफएम आप कह रहे हो, एडवोकेट नहीं कर रहे
नहीं
हो।
नहीं नहीं, मोटर सर मैं पीएफएम मेटल एक्रेलिक इनिशियली सर, बेसिकली प्रोस्थेसिस दो तरह के होते हैं आपके, एक होता है प्राइमरी,
हम्म
ओके, एक होता है डेफिनेटिव।
हम्म
जो प्राइमरी प्रोस्थेसिस है वो आपको हमेशा सॉफ्ट लोडिंग के साथ में देना है। परमानेंट प्रोस्थेसिस आप हार्ड दे सकते हो, इवन इन फुल माउथ एंड इन सिंगल इम्प्लांट केसेस,
आजकल
ओके।
तो ट्रेंड ये है ना कि जैसे पेशेंट विल से कि भाई मेरे को तो सिंगल सिटिंग में ही आप डेफिनेटिव प्रोसेसेस दो भाई।
सर आप पीएमएम में दे दो ना उसको, ग्राफीन रीइंफोर्स्ड पीएमएम में, वो डेफिनेटिव प्रोस्थेसिस है, मैं खुद पहन के घूम रहा हूँ, मैं इससे ज्यादा
हाँ
क्या बोलूँ आपको।
हाँ वही मैं कह रहा हूँ ना, पीएमएम में तो देते ही हैं जनरली, पर पीएमएम में बेसल के सिस्टम्स में ज्यादा देते हैं, मैं वही बोल रहा हूँ आपको कि
तो
उनके।
सर नहीं, हम पीएमएम में सर उसमें भी देते हैं, इमीडिएट लोडिंग 2 पीस इम्प्लांट में पीएमएम में देते हैं हम।
अच्छा अच्छा ठीक है, राइट, थैंक यू।
ओके, तो पीएमएमए में देयर लॉट ऑफ क्वालिटीज, गुड क्वालिटी पीएमएमएज आर देयर, जो कि आप मतलब 3 4 5 साल भी यूज कर सकते हो विदाउट एनी
हाँ अभी तो
प्रॉब्लम।
काफी आ गए, ग्राफीन आ गया, पता नहीं कौन कौन से।
ग्राफीन, एग्जैक्टली एग्जैक्टली। तो
पता
ग्राफीन
नहीं।
रीइंफोर्स पीएमएम में मेरा भी यही है, जैसे ग्राफीन रीइंफोर्स पीएमएम में।
तो इसकी कॉस्टिंग सिंगल टूथ की कुछ क्या कॉस्ट इफेक्टिव
सर
लग
ये
रही
हम
है।
बाद में डिस्कस करेंगे,
ठीक
तो
है
पहले फटाफट प्रेजेंटेशन खत्म है, लोग जा रहे हैं, मेरी
ठीक है
ऑडियंस जा रही है बीच में छोड़ के मेरे को।
राइट, थैंक यू डॉक्टर।
डॉक्टर कृष्णा कुमार, आई गेट बैक टू यू, जस्ट गिव मी अ मिनट, ओके। सो ये आप केस में देख रहे हैं, जो थ्रेड एक्सपोज रहे हैं, दीज आर स्मूथ सरफेस थ्रेड्स ओनली इन द सॉकेट। So in that case also we can use this. In this case also you can see only smooth surface threads are exposed in the socket. So either the bone will form or the muco integration of this will happen. You can see here the defect is there. The smooth surface threads are exposed in the defect. Either muco integration will happen or smooth surface will form over that. यार किसी ने रिसर्च पेपर पढ़ने हैं ये वाले सारे बैठ के अब, या आई जस्ट सेंड यू द लिंक ऑफ दीज।
सर लिंक दे देना आप।
बोर हो गए? बो यार बोर हो गए कि थक गए, सच्ची बताना। बोर हो गए तो मेरी बेइज्जती है, थक गए तो मेरी तारीफ है।
Actually, Dr. Saab, the topic was regarding the bypass implant. So everybody
Yes.
is waiting when you are going to start with the bypass.
सर आई हैव डन विद द बाईपास। अब आप क्वेश्चन पूछिए।
Okay, so मेरा क्वेश्चन ये है सर कि when I saw the browser, it was nerve bypass. So I thought maybe the apex apical portion of the implant.
सर बेसिकली सर दिस वाज जस्ट एन इन यस सर बताइए प्लीज।
What I thought was that maybe the apical portion you have made it narrow so that we can bypass the implant and go either in the buccal direction or
So
the.
no sir. So basically the thing that we have left the smooth surface at the end that is left out. Just let me open the slide. Okay, so basically sir what happens is we in a BW implant, sorry, B, I am tired a little bit. In the BW implant, we have a middle third is surface treated. Okay, the apex is smooth surface for the reason when you want to employ it for transcortical.
Yeah.
Okay, so when I employ it is at a transcortical, if I place the implant over here, when I want to use it a transcortical implant, the part that is coming, sir, can you please mute your mic, Dr. Akash? There's a lot of disturbance coming. Okay, so what happens is when the I will pick up an bypass implant if that would be possible. I have to open this implant, I think. Just wait on a minute. So, anyways, I will show you the packaging of the bypass implant also. Yes, sir. तो सर बेसिकली जो बाईपास इम्प्लांट जैसे ये वाला है अपना, मैं दिखाता हूँ आपको। तो जो एपेक्स हमारा स्मूथ है इसका वो इसलिए है कि जब हम इसको कहीं पे ट्रांसकॉर्टिकली एंकर करें जब भी, तो उस टाइम पे जो हमारा इम्प्लांट बाहर आ रहा है बेजल बोन से, वो वाला इम्प्लांट का पार्ट शुड बी ऑफ द स्मूथ पार्ट। अदरवाइज वहां पर हमारा क्या कहते हैं रेट्रोगेड म्यूकोसाइटिस शुरू हो जाएगा। सो the part that we want coming out is only the smooth part. That is why जो apex है हमारा smooth है।
Okay,
Got
got
it,
it.
डॉक्टर आकाश?
Got it.
जो रफ सरफेस है वो पेरिकॉर्टिकली एंकर कर सकते, ट्रांसकॉर्टिकल आना है आपको तो आपको स्मूथ सरफेस यूज करना पड़ेगा या हाइब्रिड यूज करना पड़ेगा।
Okay. And surface coating, can you just give me a little bit idea about surface coating? It cannot be
सर
re-sterilized, of course.
sir, the smooth surface one can be re-sterilized, but we don't advocate re-sterilizing the implants. Okay, the surface coating is an SLA surface treatment option. Mr. Jay would be able to explain it well. He is the master of these implants. Yes, sir. Uh, just wait on a minute. I have to do a new osteotomy for that. Just let me get my handpiece.
सर ये कहीं पे भी एनकरेज हो सकता है, तो लेंथ कैसे डिसाइड होगी?
मैम डिपेंडिंग अपॉन द ऑस्टियोटमी डेट यू डू और द एक्सरे जो आप पहले करते हैं प्री ऑपरेटिवली।
हम्म पर नहीं, वो बोन के हिसाब से आपने कहा ना,
मैम
जहाँ पे भी
अगर
फॉल्ट
अगर
हो रहा
आप
है।
अगर आप इसमें बेजल बोन एंकर कर रहे हैं या आप इसमें ट्रांसकॉर्टिकली जा रहे हैं, देन उस केस में आपको जहां पर रेजिस्टेंस फील होती है या सेकंड ड्रॉप फील होता है उस वाले तरीके से आप लेंथ को देखेंगे। आई थिंक एवरी सबने देखा हुआ मेरा R1 D1 R2 D2 वाला वीडियो देख रखा है सबने?
मेरा ना दांत पे कट गया है, अब वो घाव देखा कि नहीं आपने?
सबने मेरा R1 D1 R2 D2 वाला वीडियो देखा है?
हाँ देखे सर, देखे, यस सीन।
राइट, तो उस वाले तरीके से आप डिसाइड करते हैं कि मिड बॉडी करना है तो जहां तक आपने ड्रिल करा है आप उस हिसाब से डिसाइड करते हैं।
Sir, in case if you place the implant in a very soft bone, how can we bend that?
Sir, you use a wide diameter implant. Sir, basically ask me questions one by one. तो सर बेसिकली व्हाट हैपेंस इज जो हमारे इम्प्लांट का थ्रेड प्रोफाइल है वो इस तरह का है दैट इवन इन द सॉफ्टर बोन्स यू कैन डू द बेंडिंग. मैं भी एक्सप्लेन करता हूँ
If
कैसे
the
है.
torque is very low, in the soft bone we get a very low torque, no? If the
So you
torque is
can
very low, if you bend the implant, that then the whole surrounding the implant, the bone surrounding the implant will get distorted.
सर ये मैं आपको दिखाता हूँ एक बारी जैसे चीज़ क्या है. ये आई विल हैव टू टेक इट ऑन द मॉडल कि हमारा इम्प्लांट उन वाले सरफेसेस को कैसे सॉरी उन वाले सिचुएशंस को कैसे मैनेज करता है. ओके बिकॉज आई हैव अ वाइडर डायमीटर इम्प्लांट बट फॉर नाउ मैं दिखा रहा हूँ आपको. ये इम्प्लांट देखिए मैंने हाउ मच डिड आई बेंड द इम्प्लांट. I will pull it out of the model now, just for you all to see how much bending did I do.
No, it's okay if you get a good torque. Okay, if there is no good torque or very soft bone like a D3 or D4 bone,
Sir,
then
you
it's
use
very
a wide
difficult.
diameter implant. Let me just show. Sir, this question I will answer. Just wait on a minute. So you can see the implant bending that I have done.
Yes, 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 we can see that. Yes.
It did not break. It will not break. So now the question: how we will bend it in the soft bone? So basically, sir, what happens is our implant comes up with this kind of a thread profile. Okay, जैसर जैसर bone is strongest in compression and weakest in क्या था. ओके तो ये वाला सारे कोटेशन है फ्रॉम ऑर्थोपेडिक्स जो जयसर ने मुझे बताया था. तो मुझे सिर्फ उसमें से एक बात याद रही कि बोन इज स्ट्रॉन्गेस्ट इन कंप्रेशन. Right, so what happens is when we deploy the bypass implant. Okay, so when we deploy the bypass implant हमारे इम्प्लांट के शार्प थ्रेड्स रहते हैं.
वो डालना है
इट्स विजिबल. द इम्प्लांट इज विजिबल.
तो ऐसे रखना है इनको दोनों
द इम्प्लांट इज विजिबल टू एवरीवन.
Yes, sir, visual.
तो अब व्हाट हैपेंस इज बिकॉज ये थ्रेड्स के बीच में देयर आर बोन ब्लॉक. ओके, ये हमारा एक थ्रेड जा रहा है, ये हमारा छोटा थ्रेड जा रहा है, ये हमारा फिर बड़ा थ्रेड जा रहा है. और सिमिलरली इस साइड पे हमारा एक थ्रेड जा रहा है, एक छोटा थ्रेड जा रहा है, एक बड़ा थ्रेड जा रहा है. अगेन ड्यूल थ्रेड डिजाइन. राइट. So now what happens is when you place the implant यहाँ पर हमारा बोन ब्लॉक आ जाता है. हमारे यहाँ पर बोन आ जाता है बीच में. राइट, बोन आता है. Bone is there in between the threads. So when you turn the implant, suppose आपने implant को इस डायरेक्शन में बेंड करना है, इस डायरेक्शन के अंदर. राइट, सो ये थ्रेड हम सो ये जो फोर्स है ये हमारे थ्रेड पे कैसे जाएगा. जो हमारी ये वाली साइड है टूवर्ड्स विच वी आर टर्निंग, यहाँ पर हमारे थ्रेड्स डाउनवर्ड कंप्रेशन फोर्स लगाएंगे और जो अपोजिंग साइड है वहां पर अपवर्ड कंप्रेसिव फोर्स लगेगा. तो दिस इज हाउ इवन बेंडिंग इन द सॉफ्टर बोन ना हमारा इम्प्लांट जो है बोन को फ्रैक्चर नहीं करता.
कुछ अगर डाउट लगे तो के साथ भी चलेगा.
गॉट इट.
Okay, okay, yes, sir.
दैट्स बाय द वर्च्यू ऑफ द थ्रेड प्रोफाइल. एनी अदर क्वेश्चंस. आप पुराने क्वेश्चंस पूछ लें एक बारी. फर्स्ट का क्वेश्चन डॉक्टर कृष्णा यू हैव सम क्वेश्चन.
Sir, I have a question, please.
यस सर.
टाइप तो हमारा लगता है
If we are using your mid-body anchorage system implants of say 10 mm, 12 mm implants use कर रहे हैं, then such a case, and if we are going for a delayed protocol for any reason, then such a case, how are we using the compressive, uh,
स्टील का
मतलब
जैसे
compressive
एक
technique?
बार में एक बार
सर मुझे
तरफ से
क्वेश्चन समझ नहीं आया.
ये 2000 में
Sir, if we are, अगर हम लोग, if we are using
3000
your uh, mid-body anchorage system implant,
अगर आप हमारा मिड बॉडी
Okay.
एंकरेज कर रहे हैं, हाँ जी।
Yes. If we are using
डॉक्टर मंगल,
mid body
can you
anchorage,
mute your mic? डॉक्टर मंगल, there is disturbance coming. I can't hear डॉक्टर प्रीतिश। हाँ सर, मिड बॉडी कर रहे हैं देन।
जी अगर मिड बॉडी अगर हम कर रहे हैं सर, देन जो आप बोल रहे हैं कि हम लोग आपका इम्प्लांट सिस्टम ऑर्थोपेडिक सिस्टम पे बेस्ड है, ऑर्थोपेडिक सिस्टम पे
नो
बेस्ड
सर,
है।
no
इफ इट इज अ
sir,
मिड बॉडी,
basal implants are based on orthopedics, not our system। सर
करेक्ट
हमने
करेक्ट,
क्या करा,
ओके
हमने कुछ पार्ट बेसल का लिया, उसको कन्वेंशनल के साथ में मर्ज कर दिया। बेसिकली क्या है, हमने बेसल के एडवांटेजेस को कन्वेंशनल को दे दिया और कन्वेंशनल डिसएडवांटेजेस ले लिए, खत्म कर दिए।
ओके ओके।
तो वी मेड अ यूनिफाइड सिस्टम, इट इज नॉट बेस्ड ऑन ऑर्थोपेडिक्स, बेसल वाज। डॉक्टर कृष्णा, यस, आस्क
In
अ
the case,
क्वेश्चन।
yeah, if the inter distance is very low, we can trim the implant
हम्म,
and the abutment height. If the inter distance is very low, means we can trim the abutment height.
yeah, you can trim the abutment, you can mill the abutment inside a patient's mouth।
What is the maximum height we can trim it?
Sir, we should leave 5 mm ideally।
Really?
डॉक्टर मंगल, प्लीज म्यूट योर माइक। डॉक्टर मंगल, डॉक्टर मंगल। ओके, थैंक यू। एनी अदर क्वेश्चन? देयर वाज अ क्वेश्चन ऑफ फॉल्स स्टॉक। ये किसने पूछा था फॉल्स स्टॉक?
मेरा क्वेश्चन था सर फॉल्स स्टार्ट का।
फॉल्स स्टॉक, राइट सर। सर बेसिकली अब देखिए, बेजल के अंदर फॉल्स स्टॉक क्या होता है। बेजल में फॉल्स स्टॉक होता है कि ये आपका बेजल बोन है नीचे वाला, ठीक है। आपका इम्प्लांट यहां पर जाने से पहले ही टॉर्क आ गया, राइट। इसका मतलब क्या है कि आपका बेजल बोन अभी पहुंचा नहीं, बेजल बोन के थ्रू इम्प्लांट नहीं निकला, पहले टॉर्क आ गया, तो आपका इम्प्लांट फेल हो जाएगा। असल फॉल्स टॉर्क कुछ नहीं होता है, टॉर्क इज टॉर्क, देयर इज नो फॉल्स टॉर्क। बस ये कि आपका टॉर्क पहले आ रहा है, तो आपका जब तक बेजल बोन एंगेज नहीं है, द इम्प्लांट विल फेल। इस वाले इम्प्लांट के अंदर यू विल गेट टॉर्क इन मिड बॉडी ऑल्सो, देन ऑल्सो द इम्प्लांट विल सर्वाइव, जस्ट लाइक द कन्वेंशनल इम्प्लांट्स।
बट सर कोई ऐसा कन्वेंशनल इम्प्लांट तो नहीं है जो स्मूथ सरफेस होता है।
सर ब्रैंडमा के सारे इम्प्लांट स्मूथ सरफेस थे सर, मेरे सर। ब्रैंडमा के सारे इनिशियल इम्प्लांट स्मूथ सरफेस थे, रफ सरफेस तो मरने के आसपास बने हैं उसके।
ओके, बट सर कोई अभी तक नहीं लाया, बिल्कुल नया है ना, तो कॉन्सेप्ट डाइजेस्ट नहीं हो रहा
Sir,
है।
I think,
अरे
sir,
सर,
I think, sir, let me answer this question if you don't mind. Actually,
सर प्लीज प्लीज प्लीज।
ओके
rough
सर।
surface, rough surface does not mean that it will not it will osseointegrate, and smooth surface won't osseointegrate. By increasing the surface area, we are trying to reduce the time so that the osseointegration happens earlier. It happens faster because all the companies are trying to get it within 6 weeks. So that is somewhat around 1.5 months rather than 3 months. But yeah, it depends on the patient factor also. It is not solely dependent on the surface coating or the rough surface. Even the smooth surface will implant, even if you put a rod of plain pin like without any screw, even then titanium will osseointegrate. That is a property of titanium and not the surface of the like the implant. By having a smooth surface, we will have to wait a little bit more for osseointegration. That's it.
थैंक यू डॉक्टर आकाश, थैंक यू सो मच फॉर सच ए नाइस आंसर। तो फॉल स्टॉक वाली सर प्रॉब्लम बेजल के अंदर होती है कि आपको बेजल बोन से पहले टॉर्क आ जाता है, दैट इज वाई द इम्प्लांट फेल्स। इसमें फॉल स्टॉक नहीं, टॉर्क इज टॉर्क। Okay, and there was one other question Dr. Jessica, I think, asked. So, Dr. Jessica, basically, in our system, what we try to do is, suppose this is the soft tissue level, right? There is a line on the abutment. You see, this is a groove cut on the abutment. We want to submerge this groove inside the gingiva. This much. Dr. Jessica, you there with us?
Yes, yes, I'm here, Dr. Gagan.
तो
Carry
मैम
on.
बेसिकली इसका इसका एडवांटेज क्या रहता है? सपोज ये मेरी ड्राइंग पुअर है, पर आप समझ लेना प्लीज. सो देयर इज अ ग्रूव कट ओवर हेयर एंड उसके नीचे हमारा अबटमेंट का बेस पोर्शन होता है, इसके नीचे नेक होती है, इसके नीचे बाकी सारा इम्प्लांट होता है. सो वी नीड दिस काइंड ऑफ प्लेसमेंट. वाई? बिकॉज जब हम प्रोस्थेसिस लगाते हैं वी नीड अ समवॉट इमरजेंस प्रोफाइल ऑल्सो. सो दिस गिव सिंगल टूथ में बहुत अच्छा इमरजेंस प्रोफाइल. सो इतना आप सबमर्ज कर सकते हैं. सेकेंड थिंग, जो हमारी इम्प्लांट की लेंथ रहती है अब नेक की, दैट इज 3 मिलीमीटर. जो ये वाला पोर्शन है दैट इज 3 mm. Okay, so this is 3 millimeters. So even if you have a soft tissue collar or suppose 4 to 5 millimeters, आप थोड़ा सा इम्प्लांट को सबमर्ज कर दीजिए till all the threads are inside the bone, subcrestal. Got it? Before the surgery, before placing the implant, you can take a perio probe, measure the depth of the soft tissue with the perio probe, how many millimeters is there. Then you have 3 millimeters over here, and then you can adjust it accordingly. Got it, Dr. Jessica? Still not clear?
Yeah, I have doubts. I have doubts regarding
Yes,
this.
ma'am.
Maybe
Please,
when I
please, please.
start doing it, the collar that you say, the 3 mm collar,
Hmm.
will that be submerged within the bone or not?
Ma'am, no.
No,
You
right?
you
So,
can you can submerge it a little bit inside. Suppose, may I give you a case? If you have a knife edge ridge, okay, I'll draw it bigger. Suppose I will draw it at the size of the implant then. So suppose you have a knife edge ridge, right? So in that case, if you place it at the level of the gingivana, then somewhat thread will be exposed. So what you can do, you can place it a little bit inside so that your neck is entering the knife edge partner and all the threads are submerged. So you do it that way. That's the advantage of a narrower crestal profile. Okay, basically, what does a narrow crestal profile do for you? It basically improves the peri-implant tissue health. Okay, because a small part of titanium is only coming out, and apart from that, you can also submerge that in the knife edge, the thinnest portion of the knife edge. Got it?
I understand that, but I really feel this will be a complication in aesthetic zone because this 3 mm height in your case is not flexible. So we
No,
cannot change. The collar height cannot be changed. So
ma'am.
I
Basically,
personally feel कि aesthetic zone में दिक्कत आ सकता है while giving a crown, but let's see. Let's start doing and then I'll know.
Ma'am, I have given myself in aesthetic zone. It's not the bypass implant, it's the cross. Because जब ये मेरे implant करा था तो bypass था नहीं system हमारे पास में, right? But बात वही है, मैंने आपको ये चीज पहले बताई थी. With the patient in high aesthetic zone with a high smile line, I already mentioned as a contraindication.
So like basal implants में ज्यादातर वो गैप हमेशा visible होता है, जितने cases मैंने देखे
कौन
हैं.
सा गैप?
I mean वो जो transgingival gap होता है या वो abutment के नीचे का जो gap होता है, that is majority of the times
No,
that is visible.
ma'am, that is basically a surgeon dependent thing, right? That's not a limitation of the system. You can get very good emergence profile with the single piece implants. I do. Okay, I might have some cases if you allow me so. Let me just
Sir,
find
sir,
them.
sir, sir, let me
Yes,
try
ma'am.
to explain the thing what Dr. Jessica is asking. What happens is when it is done after, like basal implant, when we are doing after immediate extraction, then intentionally some of the surgeons trim it to compensate for the bone loss because the bone is going to get lost, resorption is going to be there, and that creates uneven bone loss. And because of that, the food lodgement is there. So they equalize it so that they compensate the bone loss which is going to happen and they create a gap which is self cleansing. So she I think is talking about that zone.
नो 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 सर, नहीं, ये मैम बेसिकली मुझे मैम का क्वेश्चन ये नहीं है. मैम का क्वेश्चन है बेसिकली इन टू पीस इम्प्लांट्स ना, आप इम्प्लांट क्रिस्टली प्लेस करते हैं, राइट? एंड देन डिपेंडिंग अपॉन द सॉफ्ट टिश्यू हाइट जितनी भी है, यू सिलेक्ट एन अबटमेंट अकॉर्डिंगली.
That's exactly what I want to know, Dr. Gagan.
यस. तो मैम हमारे सिस्टम में क्या है कि हमारे सिस्टम के अंदर लेंथ ऑफ द अबटमेंट इज फिक्स्ड. राइट। जो सॉफ्ट टिश्यू की कंपनसेशन है, आपको इम्प्लांट की प्लेसमेंट डेप्थ के साथ में कंट्रोल करनी रहती है।
Okay.
राइट, if the soft tissue is narrow, then more of the neck will go inside.
आई अंडरस्टैंड दैट, बट अगर नेक बाहर रहता है तो जो
मैम
हमारा अबड
मैम मैम देखो, जो नेक अगर बाहर रहता है, अगर आपके सारे थ्रेड्स इनसाइड हैं, नेक अगर बाहर रहता है, तो वो इम्प्लांट के लिए कोई कॉम्प्लिकेशन नहीं है, बट दैट क्रिएट्स अ प्रॉब्लम फॉर द हाइजीन मेंटेनेंस एंड एस्थेटिक्स ऑफ द पेशेंट।
दैट्स
ओके।
एग्जैक्टली
तो
व्हाट आई
तो
वांटेड टू नो।
तो
तो
मैम
हमारा
उसके
जो
लिए, उसके कंपनसेशन के लिए व्हाट वी डू इज, हम जो अबटमेंट पोर्शन है ना, हम उसको भी सबमर्ज कर सकते हैं लिटिल बिट। मैं वही एक केस दिखाना चाह रहा था, मुझे एक मिनट देखने, मैंने किसी प्रेजेंटेशन में करा था उसको। सो यू विल गेट टू नो कि मैंने कैसे सॉफ्ट टिश्यू मैनेजमेंट करी है, इवन ऑन एन इमीडिएट एक्सट्रैक्शन केस। जस्ट लेट मी सी इफ आई कैन फाइंड दैट। Meanwhile, any other questions?
Sir, I have a question.
Yes, sir.
One you showed one of your case, in the full mouth case.
Hmm.
There you have engaged pterygoid plate with this your uh,
Yes, sir.
compressive implant. Is it
Mm-hmm.
necessary to engage the pterygoid plate there,
Uh,
or we
sir,
can
sir,
end it
uh,
with
sir,
fibula,
सर, जो
fibula plate?
जो कन्वेंशनल के अंदर भी, व्हेन वी इवन प्लेस द इम्प्लांट्स इन कन्वेंशनल टेरिगोइड्स आल्सो, in that case also it is preferred that you perforate the pterygoid plate and engage the implant in that.
Yes, yes, we do that.
So we should do that.
Okay, okay, fine.
Any other questions? Any other questions? I'm just trying to find that webinar that I showed on. Just give me a minute. I may be able to find that. Meanwhile, other questions?
Dr. Gagan, you can share it with me later on, no problem.
No, I just can't remember which webinar. Basically, na, I try to make new presentation every time it's whenever possible. Na, just give me a minute. I may be able to find that. Meanwhile, other questions? I think this might be the one. You can see I haven't trimmed the abutment. I basically submerged the abutment inside and get the proper emergence profile out of it. This is an immediate extraction case. They were stitched basically. Now this side has also healed a lot better. You can see this kind of aesthetic results you can yield from a single piece implant. This is another case. You can't even tell which is the crown. That is such a good emergence profile. Dr. Jessica, can you appreciate that?
I really can, doctor, but mera question was exactly the opposite situation. What if the collar height is too much into the oral cavity and not submerged due to some reason or some case?
Ma'am,
Because it does
नहीं,
happen a lot of times. तो क्या हमारा prosthesis जो है,
मैम ऐसा ऐसा क्यों होगा? मतलब मुझे बात समझ नहीं आ रही जो आप कह रहे हैं कि आपका इम्प्लांट बाहर रह जाएगा, आप कह रहे हैं।
इम्प्लांट नहीं, कॉलर?
कॉलर मैम, आप फिर ड्रिलिंग उसको जब आप, मैम देखिए, हमने अपने इम्प्लांट में क्या करा है, हमने अपने इम्प्लांट में आपको सॉफ्ट टिश्यू लेंथ दी है, हमने आपको थ्रेड की लेंथ नहीं दी। सो द लेंथ इन आर केस इज फ्रॉम द बेस ऑफ द अबटमेंट टिल द एपेक्स। ओके, जैसे सपोज दिस इज माय अबटमेंट, this is my collar, and this is my thread profile. So length is from this part to this part, okay, from the
Okay,
hip.
okay,
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 this is the
okay.
neck, this is the implant length. So आप ड्रिलिंग को पहले ही यहाँ से कैलकुलेट करेंगे ना, आप ड्रिलिंग जब ड्रिल कर रहे हैं, you will calculate drilling depth from the soft tissue. You will see the thickness of the soft tissue, then you will see the width of the bone, then you plus them, and then you adequately select the implant.
Okay, got it. Extremely sorry because I thought the length was
You
from the
you thought the
threaded
length was
portion.
this one from
Yeah,
here.
yeah,
Okay, no,
exactly.
no, no,
Got
length is from here.
Okay, got it. Thank you.
Got it, ma'am? कोई अभी भी doubt है? Please let me know.
No, no, I got it. I got it.
Because
Thank you.
I want you all to be using this implant seriously, on a very serious note ना, I want you all to be using this implant, and remaining एक चीज रह गई, इसमें तुम्हारा टू पीस सिस्टम है हमारा जो, तो इसमें क्या है, सिमिलर टू द वन पीस इम्प्लांट, इसके अंदर आप रिट्रीवेबल प्रोस्थेसिस दे पाएंगे अपने पेशेंट को. बेंडिंग वुड बी देयर, bending would still be there, you can bend the implant like that. Second thing, you can give a screw retained prosthesis over that, or otherwise what you can do is you can just get the routine prosthesis with a screw access hole, cement them over, loosen up the screw, retrieve the prosthesis, remove the excessive cement, everything, then again screw in back.